If you think you need a clinical assistant when you just start treating adhesions, you don't. I graduated chiropractic school in 2010. I hired my first clinical assistant in 2018. That was 6 years ago from now, because now it's 2024. So for 8 years, I did not have a clinical assistant. What's been happening is our program coordinator, Dr. Matt Maggio for Adhesion Release Methods, has been talking to a lot of chiros, PTs, and massage therapists who are really interested in doing this adhesion work. And their primary objection is, well, I don't have a clinical assistant, and then they never pursue trying to fix chronic pain. And that's a huge problem because you don't realize that you can treat adhesions without a clinical assistant. And while I wouldn't do that, because at this point my skill level is where it's at, and I just don't want to water down my treatment effect, you should absolutely start doing that, because if you start treating adhesions within the next 2 to 4 weeks and you actually know what you're doing and you educate yourself to do this well, you're going to get better results than anything you've ever done before. So what I'm going to do is I'm going to go down the list of these 12 structures. The first four, actually, the first three do not require a clinical assistant. I'm just going to fly through them real quick. And then the other 9, we typically do use an assistant for. And I'm going to talk you through what I'm doing and how it feels, just so that you can judge for yourself and realize that you can start treating adhesions without a clinical assistant. So starting at the top. So the first thing is the first 3 structures are all neck structures that don't require a clinical assistant. So in other words, I would expect somebody who didn't have an assistant to be much more effective at treating the neck stuff than the lower body stuff. Because the lower body, you typically have to move legs, and the upper body, I'm just moving her head by myself, which is much easier because her head weighs less than her thighs and her legs. So if I'm doing the suboccipitals, I just stick my fingers in here. I have other videos showing how to do the suboccipitals, especially in our curriculum for adhesion release methods. So I'm not going to do that today, all the little pieces to the protocol. But if I find her C2 spinous process, I'm on the midline, I'm tilting her head, I'm sinking in, I'm bowing the semispinalis capitis, I'm sinking deep. I tension 1 with my fingers, tension 2 with my lat, and then I'm pulling. And right now I'm treating her rectus capitis posterior minor. This is how we do it in adhesion release methods. Massive tension for her. This is moderate to severe adhesion. She needs her neck treated. I did this effectively by myself. Then we have the medial cervical erectors. So if I come right off the spinous process of C5, C7, I'm holding my hand by her skull. My middle finger and index finger are sinking deep using my bicep. And then I'm pulling tension 1 with my fingers and tension 2 with my lat. And then I'm going to come up and I'm leaning forward. As I'm pulling back with my elbow, my lats are contracting, and I'm sliding up her neck. Severe tension, severe adhesion. That was horrible. You think that's funny?
I'm just like shocked.
She's shocked she has so much adhesion. So very effective. Again, I'm by myself. So 2 primary structures for chronic neck pain. Nerve roots at scalenes. I would say arguably the most important thing for any person or provider, doctor or therapist who wants to treat chronic neck pain effectively is to learn how to treat the nerve roots at the scalenes. So if I'm holding her with one hand here, I'm taking this thumb. Ooh, I'm sorry, you okay?
I'm good.
Okay. So if I find one of the nerves, here's C6 right here, that's stuck. It doesn't want to bow. So then I'm going to take the medial edge of my thumb tip, and I'm going to slowly sink into that tissue. This is not going to feel good for her. Now I'm driving with my tricep and my lat into the tissue, and now I'm fulcruming over my left thumb as I'm driving from my right lat. Lateral flexion's tapped out. Now I just rotate away. 3++ adhesion. That means just severe, severe, severe. That was horrible. All 3 of those spots she really needed. I did those 3 things without an assistant. This is very effective treatment too. So now we're going to get into stuff that I typically would use an assistant. Slide this way. NVS at subscap, neurovascular sleeve at subscap. Typically, the assistant, excuse me, is going to bring their arm overhead like this. I'm going to bring the piece down a little bit. And I like to have both thumbs in here because one thumb, I'm strong enough to do this, but usually I need two thumbs because I just want to take pressure off my feeling thumb. It's really hard to feel with a thumb that's also contracted. So if I can take this thumb and push down with it on these fingers onto my thumb, now this thumb is relaxed, I can feel a lot better. But because I've been doing this in a while, if I find a spot that's bad, just so I'm not going through the motions, so her long thoracic nerve that crosses neurovascular sleeve is kind of bad right here. So what I'm going to do is this is going to be easier than the neurovascular sleeve. I'm taking my thumb, I'm sinking in, and the most important thing with this is that we choose our depth and we choose our tension. When you choose your depth, the tension set should be very tiny. That's my tension set. And now because I'm over the top of this and that nerve goes that way, I can just lean. I'm putting my elbow in front of my anterior hip. So now my right treatment thumb is relaxed. Whew. And I'm just slowly bringing it down. And that was actually very easy without an assistant. I didn't need an assistant for that to be effective. But now if I'm going to do, did you enjoy that?
No.
You're a trooper. If I want to do the neurovascular sleeve right now, this spot is mild to moderately bad. Here's my depth, here's my tension. I don't like the load on my thumb. I have okay treatment. I'm bringing her arm up. See, right here, I really want help on my thumb, and it probably doesn't feel great to her. It feels a little bit more uncomfortable. And the treatment's probably 50% less effective than having an assistant is. Still can be done, and it's going to be better than anything else you could do, especially if you're on the right spot that has adhesion. But you can get it done as long as you focus on your mechanics and choosing the right spot. Then let's do some low back and hip stuff.
On my side?
Face up. So adductor magnus, don't use an assistant for either. So this is how you would do it. Adductor magnus, you're just going to lean the patient or client's knee on your side. This is gracilis. This is the hamstring. Adductor magnus lives between those two tissues. This is one of the two primary tissues that limits supine hip flexion. So if I find a spot that doesn't compress well, it may be adhesion or hypertonicity. But let's say that this spot is adhesion right here. So if I take this superior side arm, notice my forearm is in line with her femur. This is cool because now my thumb angle is going to have a good vector coming from my elbow so that my hand's not super contracted. So if I sink in here, pisiform over thumbnail, taking my depth straight in like that, my hand's probably contracted with like 2 or 3 pounds of force. That's it. The rest is coming from my pisiform as I sink my sternum in. Then from here, I'm driving towards her ish tube because that's where it originates. And then I'm just leaning with my pelvis, bringing her hip into flexion, and I'm driving my right elbow and lat towards her ish tube. And this is very effective treatment. This is exactly how I treat adductor magnus. I don't use an assistant for this one. So you can do this as well. Then we have the femoral nerve at the quad. I don't know about this one. I don't think you're going to be able to do it without an assistant. I'm going to try. So I usually start looking from the femoral nerve right under the inguinal ligament because it can get stuck to the inguinal ligament. So right here between rectus femoris and the femoral nerve, I don't like this. So that's bad. One of the things about a bad spot with adhesion, there's usually going to be hypertonicity around it. We say hypertonicity is like the smoke, but the nerve that doesn't bow is the fire that's causing the smoke. So when you feel hypertonicity or a knot or a trigger point, usually that means that there's a nerve that's not bowing somewhere near it. The problem is if you find a moderate to severe or severe nerve entrapment or adhesion that's not bowing the nerve, you're gonna need more force to sink into the spot that's stuck. So right now my concern is that my right hand is not going to be strong enough to drop this leg. Normally we might start like this. And so if I start like this and I'm leaning with just this hand, I have to pop this thumb joint, which I'd rather not do, so that my pisiform could be straight on my thumb. I'm having to do this to stay in that depth. So if I'm doing that, and then you're flexing the knee, notice my right elbow's in front of my anterior hip, so I'm leaning into my hip. So that takes some load off my hand. That was very uncomfortable for her. That was probably femoral nerve at the quad, 25% as effective as having an assistant. So I would argue that maybe this one is a no-go if they're having quad symptoms, anterior knee symptoms, or anterior hip symptoms that are coming from down here. But again, 25% of what you use with an assistant is probably better than any adjustment or PT or other thing that you might be doing. So let's get into some side lining stuff. Q line your side and face this way. Okay, so the sciatic nerve of the external rotators is one of the most common things we'll do. Normally an assistant is on a chair right in front of the table, and then they just roll with the leg straight. So you're just going to tell the patient, okay, I want you to keep your knee straight, and can you just slide it up the table for me? Go ahead, do that, Casey. Good, she's doing that now. Come on back. Have them do it once so that they know what they're doing and what to expect. You may have noticed that she internally rotated her femur as she was going up. Not ideal, but we'll do what we can. Most of the people who take our 5-day sciatica challenge, the find, feel, and fix the worst spot for chronic sciatica challenge, which is here, by the way, they don't start with an assistant. So this is one of those spots because they'll DM me or text me or email me and say, hey, I worked on this patient and I got results. They were 50% better. They were so happy. They've had chronic butt pain for 3 years and now it's a lot better. So this is a spot that you can use without an assistant. So if you find the spot in the sciatic nerve that does not bow, I'm going to say down here, and you sink in carefully and slowly into the right spot. Again, and go over this in the challenge if you're interested. Pisiform over thumbnail, sinking in. There's my depth. There's my tension. Go ahead, Casey, keep that knee straight. It's already pulling tight. Good. Drop the knee down lower. She's working a lot harder than she was before because I'm applying tension in the opposite direction. So she's doing a hip flexor workout right now. And it's taking longer than it normally would because the assistant's not moving their leg. But I'm feeling tension. And that was probably 60 to 70% as effective as it would have been with the assistant. So that will provide huge dividends for anybody who needs to fix a patient or client sciatic nerve. And then if you find one of the cluneal nerves, so if I find the cluneal nerves in here and one of them, they come across like this, they're very important to deload if somebody has chronic disc pain. Hers don't feel too bad. Her superior gluteal nerve, which is going this way, is worse. So for this, you're just going to have them put their knee on the table, and you're just going to say, Casey, can you flex your hip? So she's bringing her knee up towards her belly button, sliding up the table. Good. Come on back. So I find my spot that's not bowing and pushing. I sink my finger in here, and I create tension going up against the nerve. Go ahead, Casey. And she's bringing her knee up just above her belly button. And that's it. And that was probably 50 to 60% as effective as with an assistant. Still very doable. And then we have, let's try the femoral nerve at the psoas. Slide back towards me. I'm not sure about this one either, because what happens when you bring the hip backwards is a lot of the abdominal muscles will contract. And the big issue with this is this stuff's deep and you need to keep this stuff passive. So Casey, can you go ahead and bring this leg backwards for me? Good. Good. Come on forward. So that's all you're going to have the patient or client do is to bring their leg backwards and straighten it and bring it down. You're going to find your spot that doesn't bow. So let's say this spot is not bowing. Lotion. You're going to get your lotion so you don't irritate their skin. How funny. So find your spot. You're going to sink into the tissue. Choose your depth. Choose your tension. Go ahead, Case. I know. Keep going, keep going, keep going, keep going, keep going, keep going. Good. So that was surprising to me. I probably got 60, 70% effectiveness. Although what happened in the last third of that motion is her abdominal muscles started contracting because she started extending her lumbar spine and the abdomen was trying to keep it down. So you're just going to have to be mindful of that, because if the abs kick you off, then if you don't stay in the tissue, they're just not going to get an immediate result from the treatment you do. So that's that piece. Let's try the sciatic nerve at the hamstring. Can you lie face down?
Do this one, please.
We're doing this one, guys. So the sciatic nerve at the hamstring, you're going to find your spot. The patient motion is going to be, when you find your spot, they're just going to hold this, slowly strengthen your leg, or stretch, lengthen. Thank you. Just like that. The hard part for her is going to be that you're going to see, because I did this yesterday with James behind the camera, and I was doing this because it was just James and I. We'll see how it goes. So you're going to find your spot that doesn't bow, whether it's at the sciatic nerve, at the hamstring, or at adductor magnus. So her medial hamstring is not bowing off the sciatic nerve. I would suggest starting with your leg up here so it stays relaxed until you pick your spot. So right now I'm on the sciatic nerve. I'm coming off of it a little bit, and now I'm on the medial side, and I stay parallel to it, and now I'm locked on. And now, actually, I like it like that. Go ahead. Yep, keep going. Keep going. Keep going. Good. That was okay. 40 to 50%. It's hard for, I noticed you might want to try sliding it down your leg. And then what I noticed when I took the leg away, she wasn't able, it just fell like that. And then it was hard for me to maintain tension underneath my finger. So this one will be hard, but again, if they have a sciatic nerve entrapment at their hamstring and this is their problem, you getting any amount of that adhesion reduce is going to be enormous for the patient or client. And then the tibial nerve, right at tibialis posterior. So if you find a spot, brutal. She's got globs of glue in here. All the basketball championships she won. So for this, she's just going to dorsiflex, but we'll see if she can dorsiflex. Go ahead, Casey. She's using her other. Okay, that kind of works, but not all patients or clients might be able to do that. What I'm going to suggest is you do this. So if I put her toes right here, and then I find my spot, thumb, pisiform over thumb, depth, tension, and now I'm dorsiflexing. This is way better. This is 75% effective maybe, but I'm actually staying on the nerve and I can feel everything. So that you can do yourself, and you just dorsiflex for them in order to treat that tibial nerve spot. And the last piece is the spinal accessory nerve. Come on up, Case. People with chronic neck pain, a lot of them have levator scap pain or symptoms. It's usually a nerve entrapment. So for this, it's very doable because you're going to have the patient or client move their own head in the direction they need to go. So you're going to have them, Casey, put your left hand on the top of your head. Yep. And then you're going to flex down and then laterally flex as you're going. Basically doing a levator scap stretch. And that's what you're going to have them do. So you're going to find your spot where the spinal accessory nerve is stuck to levator scap, or if it's stuck to the rhomboids down lower. and then you're going to get set up. So thumb, pisiform over thumb, sinking in, taking depth, dropping your body weight to maintain tension. Go ahead, Case. And it's pulling. This is really effective so far. Good. Keep going, keep going, keep going. Good. I'd say that was 75-80% effectiveness. It was a little ratchety just because we don't have an assistant moving their head, and then you got to maintain the tension the whole time. But very doable to treat levator scap problems, nerve entrapments around the levator scap without having a clinical assistant. So I hope that this is inspiring and helpful to those of you who are intrigued by this world of diagnosing and treating adhesion, but are nervous or scared to do it because you don't have an assistant. Again, I didn't have one for 8 years. As you become more proficient with your hands and then you get an assistant and you realize how much more effective it is, it'll just make your world a lot bigger and you'll be able to help people a lot faster and more effectively and increase your rates faster too. But until then, what we typically recommend for all of our adhesion release methods providers is you do the hard work first. And the hard work is doing the work without an assistant, learning how to feel the tissue, learn how to diagnose the tissue, learn how to find the nerves that don't bow, feel the nerve, feel the difference between a nerve and a tendon, trace the nerves, the sciatic nerve from the butt cheek into the hamstring, into the tibial, common peroneal nerve, into the deep and superficial peroneal nerves, into the medial and lateral plantar nerves, all the way into the foot. You practice doing these things, your mind is going to be opened up every step along the way, and you just pay attention to what you're doing. And then you start treating people, and you may not know what you're doing, but you do the best you can, feeling for tension and feeling for a lack of compressibility. Have the patient move and lengthen the tissue so that it tears it. And then typically, if you recheck the provocative test or the range of motion immediately, they will likely notice a difference as long as you are in the right spot. So the reason why a lot of massage or rolfing or fascial manipulation or whatever doesn't work is if there's a little tiny angel hair pasta nerve somewhere in the body, you have to be right on the spot that's entrapped in order to fix it. And if you're in the right spot, there is wiggle room to not have perfect technique. And so this is the whole purpose of this video is I want people who are inspired by the work of adhesion release methods providers to feel hope that you too can do it. It's not as it's difficult work, but all it is doing the hard work every single day, which just means showing up. So I hope this is helpful. Please feel free to comment below if it is, or reach out to us if we can support you in your goals and dreams and practice in any possible way.